Hello, my name is Abdulraheem Yacoub. I'm an associate professor at the University of Kansas, and I would like to share with you the success we're having with the clinical trials of the addition of parsaclisib in patients with myelofibrosis, in addition to active therapy with ruxolitinib, as well as all the additional clinical trials that we're designing in that regard. This data was originally presented in EHA 2020 and has been since then presented at several venues internationally. Um, Ruxolitinib, as the audience is very well aware, has been approved since 2011 for patients with myelofibrosis. It's a medication that is associated with significant improvement in myelofibrosis symptoms, in splenic volume, as well as in myelofibrosis-related overall survival. However, the benefit of myelofibrosis is not universal and it's not always optimum. Some patients do manifest suboptimum benefit to therapy. And so far, we have had no additional tools or therapeutic interventions to optimize this response or improve the depth of this response. Parsaclisib is a potent and highly selective PI3K inhibitor, particularly specific to the delta domain, the delta isomer. Thus, exhibits additional activity in myelofibrosis without the PI3K associated toxicity. The rationale for this combination is that some of the partial responders in myelofibrosis can be because of escape signaling through PI3K AKT signaling pathway, which results in escape of JAK inhibition. And the combination of a PI3K inhibitor can augment the response you get with JAK inhibition. So based on this, we designed a phase 2 clinical trial that enrolled patients who met criteria for suboptimal response as we defined at the time. And since then, this definition has matured further. And patients who enrolled on the study had been on an optimized dose of ruxolitinib for at least 6 months. On average, in our study, patients had been on therapy for over 1.5 years. And patients were on the maximally tolerated and optimized dose of ruxolitinib at the time. And despite that, they continued to meet definition of suboptimal response due to persistent splenomegaly and/or symptoms. Additional inclusion criteria included platelet count over 50 for safety purposes. The primary endpoint was the change in splenic volume between enrollment and week 12 by imaging. So the study consisted of 4 parts. Part 1 was a safety run-in phase, and parts 2 and 2, 3, and 4 included assigning patients and randomizing them to different cohorts and dosing levels. To simplify this, patients received therapy either on a daily, weekly schedule, as shown in blue, where they received a fixed dose of parsaclisib for daily schedule for 8 weeks, followed by the same dosing schedule weekly thereafter. And this was an add-on therapy to already optimized and stable dose of ruxolitinib. In green is the other dosing schedule, which was an all-daily schedule where patients received one of 2 different dosing schedules on daily basis for 8 weeks, followed by maintenance with 5 milligrams of parsaclisib daily thereafter. And this shows here in green. So patients were enrolled on the daily, weekly schedule earlier. So we have had more mature data for those cohorts, while patients who received the all-daily schedule had a shorter follow-up on protocol based on this report that I'm displaying today. This is a swimmer plot showing the duration of therapy, where almost 90% of patients completed therapy to the primary endpoint assessment at 12 weeks, and more than half of the patients continue to be on therapy at the time of this analysis. So to go briefly over the results. So in patients who have had established diagnosis of myelofibrosis and have been on an optimized dose of ruxolitinib for a median and a year and a half, the addition of parsaclisib resulted in further splenic volume reduction that was significant in the majority of patients. As you can see in the bar graph showing most of the patients showing clinical benefit, and in numbers below shows the percentage of patients achieving certainly previously predefined endpoints. This benefit was sustained and actually more profound on further follow-up at week 24, as you see on the right. We've also observed that patients who have received a 5 milligrams daily on an all-daily schedule seem to have a more favorable and continued improvement in contrast to patients who had interrupted or alternative scheduling doses. And this seemed to be our most favorable in terms of dosing schedule in terms of efficacy. One key secondary endpoint was the myelofibrosis symptom assessment form and total symptom score. As we notice in the middle, as you can see on week 12, the majority of patients have achieved symptom improvement, and many of them have met the predefined criterion of more than 50% response. We've observed this improvement in symptoms as early as 4 weeks, as you notice on the left, and this response was also durable at the 24th week, as you can see on the right. In terms of adverse events, there were very few grade 3 or higher toxicities on the all-daily schedule, which is the schedule that is picked for further development. In terms of adverse events of special interest in regard to the PI3K inhibitor class of drugs, we have not observed significant toxicities on the all-daily schedule that included more than grade 2 rash or diarrhea or pneumonitis. In regard to hematologic profile, so the combination therapy was not associated with worsening anemia. So we did not observe on therapy worsening of hemoglobin values. However, thrombocytopenia was observed and was the most common hematologic toxicity and the most common toxicity that led to drug discontinuation. Fortunately, there were no grade 4 thrombocytopenia on the old daily dosing schedule. So in conclusion, the combination of parsaclisib, a PI3K delta inhibitor, in addition to an optimized dose of ruxolitinib, resulted in further improvement in symptoms and in splenomegaly. And we identified the 5 milligrams daily dosing as the most favorable dosing schedule on protocol. This success resulted in the birth of 2 prospective phase 3 global clinical trials investigating this approach further. This protocol particularly is a global randomized placebo-controlled protocol evaluating the combination of parsaclisib and ruxolitinib for treatment-naive patients, where patients will be randomized either to group A for the combination or for group B for ruxolitinib with placebo. This study is ongoing, and the study allows crossover after the last enrolled patients have reached week 24, and also includes a long-term treatment option for patients who are benefiting from therapy. And we look forward to presenting the data from this particular clinical trial in the future. The other prospective phase 3 clinical trial is a clinical trial that adopts the add-on approach for patients already on ruxolitinib with an optimized therapy, however, suboptimum response. Patients will be randomized to either receiving parsaclisib 5 milligrams daily or placebo. And the primary endpoint is also clinical responses in spleen and symptoms. This study also allows crossover for the patients who receive placebo and have a suboptimum response and continue to meet criteria for therapy. So we look forward to more success with this combination, and we hope that this combination will redefine the standard of care for therapy for myelofibrosis, both as a first-line therapy as well as beyond first-line therapy. Thank you very much for your attention, and I would like to thank my co-authors and co-investigators for this great effort.